Hi, this is Dr. Randy Grill, the nursing home dentist, and this is my forum to talk to families and especially POAs, power of attorneys, but today I'm also including dentists. And what I've noticed, and I've got stories about, wanted one tooth removed on a 83-year-old female. I sent them to the oral surgeon. Somehow they ended up at a general practitioner who followed the community standards of treatment, and in my opinion did nothing wrong. There's no lawsuit there. I had informed the POA that there was a risk of a jaw fracture, and he fractured her jaw. But instead of taking out one tooth, he took out 10 teeth. And my suspicion that dentists were becoming involved more and more in geriatric dentistry that came about when I went to a conference last week for nursing home administrators, and one of the administrators said, yeah, we were taught this morning that as the economy tanks, more and more of healthcare professionals and vendors will be entering your arena that are new to the field. And so beware, watch, and all of that. Now, number one, why do I want to talk to dentists? Because I need help. My firm belief, and it's all over these videos, is if a person in a nursing home has long-term care, can get out, they should. You know, they should go to a dental office. Mobile dentistry, in which I do, is a compromise. Period. They should go out if they can. So I welcome the interest, but my warning is, if you've treated like I did for years in private practice, and I graduated in 76, was an Air Force dentist, and then from 79 to 98, 99, practice in private practice. You already know I had a large senior population, and what I was prepared for going into the nursing homes, well, I wasn't. And I had to scramble after things happened, like a POA didn't force me to do a more thorough cleaning, but I had stopped, and they said, well, I want you to keep going. I think they had been a dental assistant, and they were watching. Oh, you've got to finish up. And I said, no, look at your mom, she's stressed. And the POA encouraged, said there's nothing wrong. Of course, I had the records. I knew exactly what was wrong. And so I gave the POA the risks and went over things, and she said fine. And about a minute later, after I'd started again, I had a rag doll on my hands. Now this rag doll, this 80-plus-year-old female, and 90% of my patients are female or more, I thought was having a seizure. And after about a minute, I was just about to call the code blue. I can't call 911. She's a DNR. All I can do is hold her hand and be nice to the POA and say, I'm sorry. But it was a TIA. The daughter said, oh, another TIA. And so, you know, I wondered afterwards, the daughter was willing to risk a TIA or a stroke for a cleaning, but I'm not. And that was a great experience for me, to realize that POAs often want more than what's safe to give, and they'll pay for it. And so my warning is, you may have worked on 70, 80, 90-year-olds, but a 90-year-old living at home with their kids is not the same 90-year-old medically that is in full-time care in a nursing institution. For one thing, we are only taught in dental schools and only practice with McLaren's 1 and 2 patients. My practice is, I may have 5% McLaren's 2 patients and 95% 3 and 4. Now what's that? Watch the video on it. I don't have time on this to do it. So my encouragement is, do a few things to make yourself safe. Join the Special Care Dentistry, www.scdaonline.org, and it has a subgroup of the American Society of Geriatric Dentistry. Join that. They have a bi-monthly magazine that's great that I devour when it comes in. They have a meeting yearly that is critically important to meet others, and it's more important to talk than it is to go to the courses sometimes. The second thing is, there's a clinician book, and this is the older version. I've got the the newer one too, but this was just handy to get. A Clinician's Guide to Oral Health in Geriatric Patients, and their corresponding book, Medically Complex Dental Patients, for $25 at ecampus.com. And what this book will do, it will tip you in on a treatment planning technique called OSCAR, which includes their DNR, which includes the average stay in a nursing home, which the average patient is in a nursing home 1.3 years. So you're treating a person that we know by definition has a limited lifespan. And OSCAR includes that. If you're not using OSCAR for treating, planning, and SOAP, then you're not knowing your patients. It's just like, do you know, and if you fought through the thing, will you treat DNRs? It takes out our safety net of 911. I will use oxygen if needed, but it's totally takes away our safety net. Are you willing for money to do that? And that's, each practitioner has to have his risk-reward analysis, but OSCAR will help your risk-reward analysis, as will ASAPS categories for the anesthesiologist uses. Also McLaren's, which we've talked about. These are not predictors of success, but McLaren's, if they're a 3 and 4, whatever you do is going to fail after a certain amount of time. Because the fact is, staff at a nursing facility go in to ask somebody, would you like to brush your teeth? They're tired. They say no. So, and we are trained by the state regulators that they can refuse even things that are good for them. We can't go in and force them to do that. And if you do, oftentimes they have limit opening. You're going to give them a painful TMJ injury. So there's another book called Oral Health for Older Adults, homesteadschools.com. An incredible course. It'll teach you. It's the one that tipped me off to McLaren's. Also, why the brittle teeth don't hurt is as they get older, the nerve calcifies in, and different things like that. 2 or 3 hours of study, doctor, and you'll be able to connect the dots. Now, you may already been there. You may have had a residency, but be careful. Even if you had a residency or your school had a special situation, the special situation they had is not like your dental office. I guarantee it. You know, the experience you've had is not like working on a patient in a nursing home today, because Senecott in the AM gives a BM and PM has filled these nursing homes, and a little simple dime pill is something that is keeping people alive that used to die of a fecal impaction in their Sears home or their kids' Sears home back in the 20s. And so the meds have changed. What used to be IV drip 20 or 30 years ago is common in pills today. So these patients are not like anything you've ever had before. So do a little study, get involved, just use OSCAR. That's all you need to do, and it'll be a paradigm shift that will make your treatment of them safer. It's like a puzzle. I even recommend that you go to the home quickly on the way home, but do it between 7 and 3, because that's when the first shift is there, and you need to talk to the charge nurse, not on the phone. After you read the record and ask questions, you need to know their weight. Are they DNR? That's not often. Their height, all their medications. Read their psych notes, read everything, because if you've got somebody that has episodes of moods and you're in the middle of a filling, and they're taught by the regulators that they can refuse or stop at any time. I have 20% refusals at any time, at any day, that I just go, oh well. And sometimes that's just part of the job. We putter on and do something else. But in a private practice, you have different pressures than I do. And so be wise. It's like a puzzle. And so do not treat someone you don't know. Visiting the nursing home is critically important. Be safe. Connect the dots. I want the dental community to be able to help and not have any more stories than my wife and I come home and cry some nights at the stories we hear when somebody's wandered out and they've been treated like we were taught in dental school as a McLaren's 1 and 2. So be cautious, be safe, and know your patient, doctor. This is Dr. Randy Grill. Thank you very much. Nursing Home Denton.